Welcome to today's Explainer. We're looking at Polycythemia Vera, going from mystery to mechanism. Let's just jump right in. Picture this. A patient sits across from you and tells you they get this maddening, disruptive itch every single time they take a hot shower. But when you look at their skin, there is absolutely nothing there. No hives, no rash, nothing visible at all to explain it. It's a true bedside mystery. But then, before they even finish their sentence about the hot shower, you notice a second major clue. You look at their face and you see this deep, ruddy plethora. They literally look permanently flushed. Now, on their own, a hot shower itch or a flushed face might not scream hematology, but together, they are practically diagnostic for what we're exploring today. It's really a brilliant lesson in fluid mechanics gone completely wrong. So the crucial point here is understanding the core lesion down at the molecular level. Polycythemia vera is a myeloproliferative neoplasm, and the main driver is a genetic mutation, specifically the JAK2 V617F mutation. Basically, this mutation permanently flips the switch downstream of the erythropoietin receptor to on. In plain English, those red cell precursors are getting a constant keep-producing signal. They're just churning out red blood cells completely independent of the body's actual oxygen needs. And just how prevalent is this specific mutation? It's the underlying driver in about 95% of PV cases. That remaining 5% or so is usually driven by a less common JAK2 exon 12 mutation. But honestly, the result is exactly the same: clonal erythrocytosis. You've got this rogue stem cell clone that has entirely stopped listening to the body's normal physiological feedback, telling it to stop making red cells. And this brilliantly illustrates how the clinical picture flows directly from simple fluid mechanics. When you have too many red cells, you raise the blood viscosity. And thick, viscous blood flows terribly through small vessels. Take dizziness and visual blurring, for example. That's just impaired cerebral microcirculation. That plethoric, flushed face, that is literally your cutaneous blood vessels visibly engorged with all that excess red cell mass. What about the pruritus, that hot shower itch? We think that comes from abnormal histamine and cytokine release from the proliferating clonal cell lines, specifically mast cells and basophils getting triggered by the warm water. And finally, erythromelalgia, which is this burning pain and redness in the hands or feet, reflects microvascular occlusion. It all just ties right back to the blood being way too thick. Now, what's really interesting about this slide is the counterintuitive paradox that all this hyperviscosity creates. Beyond just causing uncomfortable symptoms, the true clinical threat of this disease, the thing that actually drives morbidity and mortality, is thrombosis, thick blood clots, right? But paradoxically, polycythemia vera also carries a genuine bleeding risk. Especially when platelet counts get really high, patients can develop abnormal platelet function and even acquired von Willebrand factor abnormalities. It's wild, because this disease is actively pushing the hemostatic system toward dysfunction in both directions at the exact same time. Speaking of that clotting risk, I want to highlight a critical diagnostic pearl. Thrombotic events in this disease can happen in some very unusual, specific locations. A massive red flag is Budd-Chiari syndrome, which is a splanchnic vein thrombosis. If you see unexplained Budd-Chiari syndrome, especially in a younger patient, it should actively and immediately prompt you to screen for an underlying myeloproliferative neoplasm. PV is actually the most common culprit here, and this should never just be treated as an isolated liver event without digging deeper. So, how do we actually confirm our suspicions? Let's break down the current WHO diagnostic criteria. To make the diagnosis, a patient needs either all three of the major criteria or the first two major criteria combined with the minor criterion. The major criteria look for exactly what you'd expect: elevated hemoglobin or hematocrit, a bone marrow biopsy showing hypercellularity across all three lineages, what we call panmyelosis, and, of course, the presence of that JAK2 mutation we just talked about. But let's look a little closer at that minor criterion, because it is clinically beautiful in its logic. The minor criterion is a serum erythropoietin, or EPO level, that drops below the normal reference range. Why is a low test result so incredibly useful here? Because it brilliantly proves the mechanism. It reflects the body's appropriate suppressive feedback response. Your body senses the massive excess of red cells and just shuts down EPO production, essentially screaming at the bone marrow to stop. But because of the JAK2 mutation, the marrow clone just keeps churning them out anyway. Before we move on to treatment, I want to give you a standing clinical rule to keep in your back pocket. Whenever you're evaluating a patient who presents with systemic pruritus or severe itch, your mind should immediately jump to three leading diagnoses: primary biliary cholangitis, polycythemia vera, and cholestatic jaundice from other causes. By understanding the mast cell mechanism in PV, you can anchor this disease firmly in that essential differential pattern. Once we have a diagnosis, what actually drives how intensely we treat the patient? Well, it all comes down to risk stratification. And thankfully, it is refreshingly binary. A patient is high risk if they are over 60 or if they have any prior history of thrombosis. They are low risk if they are under 60 and have absolutely no prior history of thrombosis. This simple split is incredibly important because it's the single strongest determinant of our treatment strategy, even more so than the patient's daily symptom burden.
Now, regardless of whether they are high or low risk, we have a very strict target for the thickness of their blood. We want the hematocrit strictly below 45%. Why this specific number? Because we have robust trial evidence that directly links maintaining hematocrit control below this threshold to a meaningful reduction in cardiovascular death and major thrombotic events. It is a hard, evidence-based line in the sand.
Let's see how this builds into our baseline management strategy. For absolutely all patients, regardless of their risk category, we initiate this foundational two-step approach. Step 1. Administer low-dose aspirin to immediately help reduce that severe thrombotic risk we talked about. Step 2. Perform therapeutic phlebotomy, which is essentially bloodletting, to physically remove the excess red cells and hit that critical hematocrit target of below 45%. For high-risk patients, or low-risk patients who become highly symptomatic, we need to add cytoreductive therapy. And here is where we're seeing a genuinely significant, really exciting shift in the modern NCCN guidelines. Traditionally, the default first-line agent was hydroxyurea. It's effective for symptoms, but it carries known long-term complications like mucocutaneous toxicity and an association with skin cancers over time. Today, ropeginterferon alpha 2b has moved into the preferred first-line status for both low and high-risk patients. The accumulating trial evidence shows it provides superior long-term hematocrit control, but more importantly, it is uniquely associated with a meaningful reduction in the actual JAK2 mutant allele burden itself.
And this isn't just a medication swap. It represents a much broader philosophical shift in how we care for these patients. Current guidance explicitly frames this as a move toward earlier, far more proactive intervention. The goal is no longer just reactive symptom control, waiting around for hydroxyurea to fail. The goal is true disease modification, actively working to reduce the underlying mutant clone over time. Now, ropeginterferon does require regular injections and has its own tolerability profile, so the choice depends heavily on the patient, but the shift in strategy is profound.
To round out the management picture, there are a few additional factors to keep in mind. The JAK inhibitor ruxolitinib has a very specific role for patients who have hydroxyurea-resistant or intolerant disease. Also, because of the massive cell turnover in this condition, hyperuricemia and gout are pretty common and should just be managed conventionally. And lastly, we always have to maintain ongoing surveillance for acute leukemic transformation. This remains a long-term risk for these patients, reflecting their shared position within the broader myeloproliferative neoplasm family.
So let's pull this whole picture together. You have a mutated stem cell clone driving red cell overproduction, completely ignoring the body's feedback. That excess mass thickens the blood, impairing microcirculation and creating a massive thrombotic threat. We manage it aggressively to keep that hematocrit down, and our treatments are getting much smarter and more proactive at targeting the mutation itself. So, the next time you see that unmistakable ruddy, plethoric face, or you hear about a maddening itch that strikes right after a hot shower, don't treat those as unconnected complaints. Ask yourself, what is making this blood too thick? Because in Polycythaemia Vera, understanding that single mechanical mechanism unlocks the entire mystery. Thanks for joining me on this explainer, and keep asking those deep clinical questions.